How old are you?
49.
How long has the knee been bothering you?
About a year.
Does your knee swell?
Yeah, a little bit.
Have your symptoms generally been on this side of the knee?
Yeah,
Is it impairing your ability to be active and to do things?
it is.
Okay. Would you say that you got some relief with the cortisone injection at one point
Yes,
and that stopped being beneficial?
correct.
Would you also say that a lot of your symptoms are in the area over here?
Correct.
You occasionally get symptoms up in here.
Yes.
Okay. And bending your knee up, do you also get symptoms in this area here along the joint line?
A little less so, less sharp pain, but yes.
Okay. But arguably are most of the symptoms over here?
Correct.
The plan today is a left knee arthroscopy, evaluation of the medial compartment. What's unique about his case is that his primary complaint is more bone pain than joint pain, which is essentially an insufficiency fracture of his medial tibial plateau and medial femoral condyle around the anterior third of each. So we'll start with a routine arthroscopy, articular cartilage debridement, meniscal debridement, all in an effort to sort of minimize the symptoms that might be generated from pathology that's present intra-articularly. Typically what we find is that the pathology intra-articularly correlates where the subcondylar insufficiency fracture, represented by the edema, is seen by MRI. So his medial tibial plateau wear is really just where the MRI shows the insufficiency. Here is his medial femoral condyle, large area of involvement. So you can see there's sort of a kissing lesion environment with bipolar disease, which is about what I expected given his pre-op radiographs and pre-op MRI. So as I look at this, I'm planning out mentally as far as how many pins to use. I suspect I'll do 2 in the tibia and 2 in the femur, and I'll space them out about 1 centimeter apart. The other thing that I found particularly useful is to line up the intra-articular pathology with where I know the MRI findings are, just to verify and confirm. So this is the anterior third of the tibia. This is exactly where he would complain of pain, and it also lines up with where the pathology is here in the femur and the tibia. So that's a nice little trick to sort of correlate what you see by MRI with what you're seeing intra-articularly. Pin, please. So what we're going to do is, I place the spinal needle sort of dead center where the I'm going to try to center it, where the degeneration is, and I'll probably go just behind it and just in front of it. We'll start with the tibia.
Fluoroscopic imaging in the anterior posterior and lateral planes is utilized to confirm proper nail placement.
So I want to be just beneath the subcondylar surface. I want to track so I don't go too close to the subcondylar bone on the lateral side. And I can feel the opposite cortex there. Second pin, please. Try to stay parallel to the first pin, spreading out by about 1 centimeter. Remember, the tibia is triangularly shaped, so as you move more anterior, it'll be shorter. I'm getting a rough idea that we're collinear and that we are on the opposite cortex, but the drill bit, the cannulated drill, will help assure the opposite cortex, 11 blade. We can actually take one measure now. We can take one measure now with the indirect ruler just to get a rough idea of where we're at. For the anterior one, I just want to make sure I'm generally on the, yep. So because it's triangularly shaped, it looks like it's through the hole, but it's not. So this is 65. So that's about right. So 65 for the anterior one. We're going to prove it with the drill. And the posterior one is 70. Okay? So that's helpful. I'm going to remove the spinal needle. We'll go ahead and drill now, and the drill is a good way to feel from a tactile perspective where we are relative from the near to the far cortex. So I like to use the drill to get a sense of feel. Good. So I think that's the other cortex right there. I'm going to do a true depth measure using an AO depth gauge. So we'll cut our pin down to length that we determine both with our indirect ruler as well as our direct depth gauge measurement. We'll impact the pin. Impactor. Mallet. The objective here is just to basically seat the impactor on the near cortex counterforce. So I'll use the C-arm to confirm we know we're juxtaposed to the tibia, so I'll stop there. Now we'll drill our second hole, and this is a way again to verify the length. So I feel myself along the far cortex. So in this instance, I know my length is pretty accurate because the tip of the drill is at the tip of the K-wire. Okay? Now, many times the K-wire will back out as the drill is coming out. The way to manage that is I'll disconnect the drill from the K-wire. I'll use a mallet to impact the K-wire. And then I'll finish removing the drill. Okay? Sometimes I can just do that by hand. We'll use the depth measure, depth gauge one more time. So we'll use the indirect ruler now just to verify our depth. In this instance, we're measuring 63, but I'm going to verify that now with a traditional AO depth gauge. So we're going to go with a 66. I just don't want it to be long on the contralateral cortex. So we'll cut our pin down to length. Just flushing it up to the near cortex, and the pin gets removed. Next, we're going to place a 1.4 millimeter K-wire under power, approach the distal femur. The goal is to have it approximately within a centimeter of the subchondral plate, directly into the area of the insufficiency fracture. I found it easier to feel the distal cortex on the femoral side than I do the distal cortex on the tibial side. We'll place our second 1.4 millimeter K-wire parallel to the first, separated by about a centimeter. So we'll do our provisional depth gauge measure. 24, which is about right. Intuitively, just that has face validity in terms of the standard medial lateral diameter of the medial femoral condyle. Go ahead. What do you got? The posterior one. Okay, we'll call it 28 for right now. Now we'll prove it with the drill. Posterior one is going to be by feel. I can feel myself on the contralateral cortex. Okay, I'm going to buy that. Okay. Mallet. This will be posterior. So we'll use the indirect ruler. We know it's firmly seated in the other cortex. Okay, so we'll use 28 for posterior. Let's drill the anterior one now. First, we'll cut our 28. This is the posterior. Next, we'll advance the trimmable nail across the medial femoral condyle and make sure it's flush with the near cortex. Okay. Last nail, we have to cut it.
The KneeBar procedure, I think, adds something to our armamentarium for a patient population that has otherwise been quite vexing. The feedback from our patients, which has been nearly uniformly successful, is that they've seen substantial reductions in pain, improvements in outcome, and they recognize that they really had no other alternatives, having exhausted non-surgical treatment and knowing that they're not candidates for anything more, such as arthroplasty or knee replacement.